Please start.
Hello,
Ma'am,
hello,
30
ma'am.
people have joined, ma'am. Can we start, ma'am?
Yeah, we can start.
Good evening, everyone. We will be presenting a case on foreign body bronchus. Our moderator is Dr. Nidhi, ma'am. I am presenting a case of Master Shubham, 6-year-old boy, resident of Saket, Delhi. The informant is mother, and history seems to be reliable. The child was brought to subject emergency with presenting complaints of aspirating and choking on a peanut 12 hours back. He had a complaint of on and off cough for past 12 hours and difficulty in breathing while running or jumping for past 4 hours. History of presenting illness. Patient was apparently well until 12 hours back when he had accidentally aspirated a peanut and he developed choking and sudden onset coughing. After a few minutes, coughing subsided, but child had on and off cough since then. Cough was dry in nature, not associated with any expectoration. There is no history of postural variation. He developed difficulty in breathing while running or jumping 4 hours back, sudden in onset, not relieved on changing posture. It was not associated with pain while breathing or fast breathing or any history suggestive of chest retractions. There is no history of fever, sore throat, running nose, hoarseness of voice, noisy breathing, bluish discoloration, difficulty in feeding. He had taken his last meal around 12 hours back. Past history. There is no history of choking in the past. There is no history of breath holding or any obvious congenital defect. There is no history of any seasonal allergies. No history of hospitalization in the past. He's not a known case of TB or asthma. Developmental history. He had acquired all milestones as per age. Presently, he's a primary school student with an above average academic performance. His vaccinations are all up to date. Personal history. He is vegetarian by diet. He has normal bowel and bladder habits. He has normal sleep pattern. Family history. There is no history of diabetes, hypertension, asthma, or any other heart diseases in the family. No history of any gross congenital anomaly in the family. Ma'am?
So,
Ma'am, my
just wait a second. Wait a second. Yeah, your history is over.
Yes, ma'am.
Okay. So, what is your provisional diagnosis on the basis of this history?
Ma'am, it's a 4-year-old male child who was present with a witnessed choking and cough, followed by difficulty in breathing, most probably a case of foreign body aspiration, bronchial
You
infiltration.
also know from your history what is the foreign body. You can say in your diagnosis.
Sorry, ma'am?
I'm saying you know what is the foreign body, so you can say in your diagnosis.
Yes, ma'am. A present witness choking and
Can you
on a peanut, ma'am.
peanut and what is the likely site
I'll,
lodgement based
bronchial
on your
side, ma'am.
history?
Bronchial, ma'am.
Bronchial.
Yes, ma'am.
Jacqueline, you have to come near the mic because your voice is getting cut.
Yes, ma'am.
So, you said the child's age is 4 years old. Do you
Yes,
think
ma'am.
this is a very common age group for a child to present with foreign body?
Ma'am, it is mostly from 6 months to 6 years, ma'am.
And what
And
is the
but it,
peak incidence in what age?
ma'am, peak incidence is
Why?
between 1 to 3 years, ma'am.
Why is this age
Ma'am,
common?
mostly there are three reasons, ma'am. One is they don't have molar, and they will be doing multiple activity at the same time, and that they won't chew properly, and that there is poor coordination between swallowing and
Never
glottic
give an
lubricant.
answer that never start your answer with first that there are three reasons. Maybe when you start speaking, you'll
Sorry,
find
ma'am.
five, or when you start speaking, you may not remember the third one. Okay.
Okay.
Never
Okay.
say in your answers that there are these reasons. You can start with your answer that this 1 to 3 years of age group, they have a tendency to put everything in their mouth, and they do that while running or jumping. They eat generally while running and jumping. They do not chew properly because of the molars, and they have uncoordinated swallowing reflexes and chewing reflexes. Right?
Yes.
There
Yes,
can be
ma'am.
more than three reasons as well. So don't start
Yes.
your answer with.
Okay, ma'am.
We know that 1 to 3 years of age is the most common age group, but foreign bodies can occur in the later age group as well. So
Okay.
you're saying that the child has probably has aspirated peanut accidentally. So, do you think we are concerned about this foreign body? Is peanut a little? What are the types of foreign bodies that can be
Ma'am,
inhaled?
the foreign bodies can be divided grossly into organic and inorganic. Organic include peanut, seed, nuts, grapes, bones, and inorganic contains buttons, beads, screw, nails, sewing needle,
Like
pen cap,
mostly
etc.
toys, pen
Yes,
caps, which children tend to put in
vessel,
their
ma'am.
mouth. So,
Yes,
are we really concerned about this peanut organic foreign
ma'am.
bodies? What are their characteristics? Sometimes they can be dangerous. Can you explain how?
Ma'am, especially in case of a peanut, nuts liberate irritant oils, ma'am. They cause local inflammation and airway reactivity, ma'am. Uh,
So
Ma'am, they
local
can.
inflammation because of the peanut oil can cause airway edema as well,
Yes,
right?
yes, yes, ma'am. And they are more prone to fragmentation during removal, ma'am. And they are
They are
missed
organic
reduced
seeds.
also, so they will
They
be mixed
absorb.
during.
What is this? What can you repeat?
Sorry, ma'am.
Last one I can hear.
Ma'am, they are more prone to fragmentation during removal, and they are radiolucent, so they will be missed during X-rays, ma'am.
Right. So why do they fragment?
Sorry, ma'am.
Why do they fragment easily? Why is peanut? Because
Ma'am,
peanut absorbs moisture from the trachea, okay, and then it swells up. When it is
yes,
swelling up, it becomes softer. One, it can fragment easily, and the various fragments can lodge into various smaller bronchi. Secondly, when it is swollen up, it can convert a partial obstruction into a more
total.
complete obstruction,
Yes,
right,
ma'am.
of
Yes.
of the thing. So, can
Yes.
you tell, uh, Jairam, can you tell
Uh,
some other dangerous foreign bodies?
Ma'am, there can be sharp objects like pins, nails, or ear clips. Uh,
What would
then
they do?
button battery. These
Sharp
sharp objects
object
can
क्या
cause.
problem है? What is
So, ma'am,
sharp?
these sharp objects can cause mucosal injuries, then perforation of the trachea
Right.
or bronchioles. Then this button batteries, it can release the chemicals and which can cause inflammation, necrosis, and again perforate. It can lead to the perforation.
Yes, and they can also, because of mucosal corrosion, corrosive fluids, it can also cause later tracheal stenosis. If
Yes,
not
ma'am.
perforation, then stenosis can also occur because of scarring and all. So
Yes, ma'am.
these button batteries are dangerous. They have to be removed as early as possible.
Yes,
Are
yes,
they
ma'am.
radiolucent or are they radiopaque?
Radio opaque, ma'am.
Yes. So not all organic bodies are foreign
Uh,
bodies. Although it is
Ma'am,
not an organic foreign body. And
uh,
what?
uh, ma'am, about 10% of the foreign bodies are radio opaque and rest all radio lucent, ma'am.
Yes. So button battery, if the cover is metallic, it can be seen on
Yes, ma'am.
X-ray. Any other foreign body which can be dangerous?
Uh, Ma'am,
Round
in
marble like marble, round
ma'am.
non-compressible slippery surface foreign bodies like marbles. They are round. They
Yes,
can
ma'am.
cause complete obstruction of the trachea, and
Yes,
they are
ma'am.
very difficult to remove. Also,
Yes, ma'am.
certain iron and potassium chloride tablets which can dissolve and cause tissue necrosis, etc., of the mucosa of the tracheas in the similar way as button batteries. Right?
Yes,
So
ma'am.
these are the some of the dangerous foreign bodies, and we should be aware of that.
Yes,
Now,
ma'am.
Jasmine, in your history, you said that a foreign body is lost maybe in a bronchus.
Yes, ma'am.
Can you tell me where all a foreign body be lost in an airway?
Ma'am, it can be in supraglottic region, it can be in trachea, laryngeal region, and in bronchi, ma'am. Mostly it is,
Supraglottic region where?
as ma'am, in 80 to, sorry, ma'am,
That's supraglottic region. Where in supraglottic?
just about, ma'am,
Just above.
just about vocal cords, ma'am.
Over the vocal cords would be taken as probably laryngeal foreign body only.
Okay, ma'am.
Foreign supraglottic generally are they're not classified as supraglottic. They're generally classified as laryngeal, tracheal, bronchial, and
Bronchi.
some percentages in smaller bronchioles. right?
Yes, ma'am.
So which is the most common area for lodging?
Bronchi, ma'am. 80 to 90%
Bronchi.
cases it occurs in bronchi, mostly in the right side, but in children, I mean younger children, the incidence is equal on both sides.
Yeah, almost equal because the right side, why right side is more common in adults or the older children?
Ma'am, the angulation is less towards the right side and it is shorter and broader, ma'am.
Right, but in smaller children it is not so. Almost they come out, they diverge both right and left bronchi at the almost the same angle.
Yes, ma'am.
There is equal, almost equal incidence, right preponderance. So suppose in your history, what are the points which tell you that this patient does not have a laryngeal foreign body? What did you take in your negative history?
Ma'am, one is the respiratory distresses I mean, the difficulty in breathing is only during exertion, ma'am. It is not present at all the time. And there is no history of any hoarseness of voice or noisy breathing, or there is no history of blues discoloration, ma'am. During complete obstruction of uh, the airway, there will be cyanosis and will be stridor, ma'am.
So what kind of stridor will be present in a laryngeal foreign body?
In-
Inspiratory or expiratory?
Inspiratory, ma'am.
Inspiratory. And expiratory stridor will be present
In bronchi, at the bronchi level, ma'am. When the foreign body is at the
bronchi
bronchi
or
level.
even intraglottic in the tracheal region
Yes, ma'am.
probably appear as expiratory stridor. So laryngeal foreign bodies, in other way, they can also present with aphonia. And
Yes, ma'am.
laryngeal and tracheal foreign bodies, are they dangerous? More dangerous as compared to bronchi?
Yes, ma'am. They are more dangerous, ma'am. They can lead to complete obstruction, ma'am, and it's sudden death.
They present with more severe respiratory. Why did you say there is no bluish discoloration?
Sorry, ma'am, I didn't get your question, ma'am.
Bluish discoloration denotes what?
Bluish discoloration, ma'am, due to cyanosis, ma'am, and ma'am, there will be complete obstruction
Yes.
of.
So from your history, you are able to assess what is the respiratory distress, right? What is
Yes,
the
ma'am.
severity of the respiratory distress? And what is the location of the foreign body?
Yes, ma'am.
Based on severity, you were saying that laryngeal. Why somebody, Jairam, I'll ask
Hello.
some other person.
Yes,
Wait,
ma'am.
ask some other person. Okay, Ananya, can you tell me why laryngeal and tracheal foreign bodies are more dangerous and they cause more severe respiratory distress?
Ma'am, the laryngeal and the
And tracheal, as
ma'am,
compared to bronchi?
ma'am, because it can cause stridor.
Stridor to symptom है बेटा. Why are they more dangerous? Why laryngeal and tracheal foreign bodies cause more respiratory distress as compared to
Uh,
a foreign body lodged in bronchi?
ma'am, um,
Okay,
ma'am,
Amir,
because
can you tell? Yeah. See, our airway is common. Larynx and trachea, it is only one. Okay? And after trachea divides into two bronchi, right? So when one is breathing through the larynx and trachea and there's a foreign body, there'll be more airway obstruction. Once the foreign body slips into one of the bronchi, the patient can easily breathe through the larynx, trachea, and from the other lung. Correct? You understand what I am saying? Ananya, can
yes,
you
ma'am.
understand?
Yes, ma'am.
There is only one larynx and trachea. The path then divides into two bronchi. So any foreign body which is lodged in the bronchi will cause less respiratory distress because the child will be able to breathe through the other lung and other bronchi. But a foreign
Yes, ma'am.
body placed in larynx and trachea, it will completely or partially obstruct the passage. So they are more
Yes,
dangerous. And
more dangerous.
we should remember that any partial obstruction or laryngeal and tracheal foreign body can anytime become complete obstruction. Sometimes change in the posture, crying, even crying by the child, they all can dislodge a foreign body which is causing initially partial obstruction into complete obstruction. We should all be aware of that, right? These are dangerous areas and they cause more respiratory distress. Now, in this case, we are saying that. Can you repeat what are the symptoms of laryngeal and tracheal foreign bodies? How will the child present if he has a laryngeal or a tracheal foreign body? Jusha, can you explain the laryngeal foreign body? What would be the symptoms?
Yes, ma'am. Most probably the child will be presenting with choking and vigorous coughing, and there will be wheeze, most probably either
No, I am
inspiratory.
asking only. Yeah, okay. Respiratory wheeze, correct.
If,
You know, larynx is an organ through which we speak, right? Glottic area. Most of your symptoms would be related to the speaking, right? So
yes, ma'am.
hoarseness of voice can be there.
Voice and
Suppose just
either
imagine a
even aphonia can occur.
aphonia can occur. And stridor is always common. Laryngeal edema होता है तो क्या problem होती है? Stridor होता है ना? Respiratory
Yes, ma'am.
stridor. And then the respiratory, if it's a bigger foreign body and it is causing severe airway obstruction, then child can become blue also. So cyanosis can also occur.
Sinus.
Besides the other symptoms of respiratory distress, respiratory distress can be present in any foreign body. The severity may change, right? In
Yes, ma'am.
tracheal, if the foreign body is in the trachea, what can be other symptoms? There will not be hoarseness of or aphonia. The body is in the tracheal region. We already said that the stridor will be not inspiratory. It will probably expiratory stridor.
Yes, ma'am.
So tracheal foreign body, more severe respiratory distress can occur, and there can be coughing, cough.
Thing, ma'am.
Now, and the bronchial foreign bodies, we already have seen what symptoms can occur with a bronchial foreign body. There's a classical triad of Jasmine, Jairam. There's a classical
Yes.
triad of symptoms found in large, when a foreign body is lodged in large bronchi. What is it?
Ma'am, cough,
And is it
wheezing,
present in your patient?
decreased air entry on the side, ma'am.
On unilateral. Unilateral
Yes.
decreased breath sounds, unilateral wheezing,
And
Okay.
cough. Yes,
this is
ma'am.
the classical triad, but it may not be present in all the patients. Maybe present in just 60 to 70% patients or even less. So other symptoms that a patient, the laryngeal with a bronchi, foreign body in a bronchi can be, yeah.
Breathlessness, ma'am.
Okay.
And on the
So,
chest. Sorry.
what did you ask for ruling out the severity of the respiratory side, stridor, aphonia, in your patient?
Ma'am, we asked whether there was any history of any noisy breathing, ma'am, or
That
there
was
was
for
any history
laryngeal body. Now, I'm asking about the bronchial body. What did you ask? Furthermore, did you ask for any respiratory distress के लिए symptoms? कुछ पूछा
Yes, ma'am.
तुमने?
We asked for any history of fast breathing or any history which is suggestive of chest retraction, ma'am.
Yes. How do you ask, Amir? How do you ask a parent about this retractions in your history? The costal, subcostal, and sternal retractions can occur, ना? Intercostal retractions के लिए कैसे पूछते हैं history में? Is Amir there? Ankush?
Yes, ma'am.
Ankush, can you answer? Good
हम
evening.
chest retractions में there's subcostal retraction होती है. So
How do you ask a parent in your history? How will he know what you were trying to ask?
ma'am,
What do you ask? Remember from your
ma'am,
pediatric days.
increased effort in breathing. मतलब जो
They
चढ़
will
के
tell
सांस
you.
ले रहे हैं.
Parents are very important. They can tell you. कि पसलियां चल रही हैं. Don't you remember that?
पसलियां चल रही हैं.
Pneumonia जब होता था बच्चे को तो they would say कि बच्चे की पसलियां चल रही हैं. So asked कि इसकी पसलियां तो नहीं चलती थी कभी भी, है ना? That is the history you ask for parent, and they can very well tell you that he is breathing more rapidly if there is a distress. सांस जल्दी जल्दी ले रहा है ना? Okay. So now from this history, we have one more thing we want to know. This is actually a witness case. we know that the parents have told us that patient has aspirated a foreign body in front of them. But sometimes, the patient may present with these symptoms of respiratory distress and all, but there is no history of having taken a foreign body, although there is a foreign body in their way. So that we call as a unwitnessed foreign body aspiration. So, can you tell Ankush how the patient present?
Ma'am, the
Patient has an
patient will.
unwitnessed event, then what can be the differential diagnosis in such cases?
Yes, ma'am. Ma'am, for an unwitnessed, it may be that the foreign body has been in place for a chronic time, for days, and the child starts to have cough and sputum, and eventually leads to a pneumonia and a fever may be there. And even on chest X-ray, if the foreign body is radiolucent, we're not able to visualize the obstruction, and we treat the patient for pneumonia, but the symptoms do not. Uh,
So one the diagnosis for a bronchial foreign
yes,
body.
ma'am.
Any other?
Uh,
Child is having a cough, stridor. What else
yes,
they
ma'am.
would?
Stridor and cough, inaudible wheeze. The child may be
So
having a
what would be the
stridor.
differential diagnosis then? What would be the differential diagnosis then?
Yes, ma'am.
There is
Ma'am,
stridor.
these stridor may we
What
can
could be
suspect.
what? See here, what I'm asking you, we don't know here that there is a foreign body aspiration. Child has
Okay.
gone to a pediatrician with history, with the symptoms of respiratory stridor, hoarseness of voice, barking cough. So, what initial
Ma'am,
diagnosis?
group is
Yeah, they
in parking का होता है.
can be
Then
there,
we have
right? And so initially they
ma'am.
would say, okay, there's a croup, then they would, or probably a tracheitis if there's a fever also, and then they will probably treat him for these things. So,
Yes, ma'am.
an unwitnessed foreign body, the child may have land up with complications, right? So, what complications can occur? And even an asthma can be,
Asthma
differential
can be a
diagnosis in
difference.
asthma can be
These.
there, especially with an expiratory wheeze present.
Yes,
But the
ma'am.
difference here could be that there could be probably a unilateral wheeze, maybe. But a bilateral wheeze can always be present in a patient because of hyperreactive airway, right?
Yes, ma'am.
So these can be differential diagnosis. So Jairam, can you tell us
Yes, ma'am.
about the case? Can you tell me about that case which you saw? Tell
Yes,
us
ma'am.
about.
Ma'am, that's the 10-year-old male child. There's a history of trauma to the teeth while playing. So he got aspirated one tooth and one tooth बाहर निकल गया इसका. So that was the history. Then actually 20 days का history था. So patient came with like complaints of fever on and off. Then complaints of breathlessness on and off. Then uh, and sputum also on and off. Only these the three symptoms were there. And patient ka examination wise, on auscultation we could able to hear crepitation and the wheezing bilateral, but more in the right side. Sorry, more in the left side because the foreign body was in the left side. But we could hear bilaterally. Then the room air saturation was almost 94%, 93 to 94% on room air.
So did they suspect any pneumonitis or what did they suspect initially? Why did they
Ma'am,
waste 20 days?
ma'am, initially they suspected pneumonia and all because of the fever history and this one. Once they get the X-ray done, then they are like it's a radio opaque. So they came to know the diagnosis of foreign body of and there was a history of trauma to the teeth also playing. So they finally came to the diagnosis of foreign body bronchus, that's teeth.
Very good. So that's how certain children may present to you. 20 people may bring a child that probably there is no witness thing, but they have a high suspicion of foreign body inhalation based on the history. And sometimes you have to prod the parents a lot and then ask them and elicit the history of having any episode of choking or persistent coughing in the past. And in this, it was a radio opaque thing, so it could be seen. It could have been discovered earlier also if chest X-ray had been done before. But in case of radiolucent bodies, the child may present to you for diagnostic rigid bronchoscopy, a diagnostic foreign body as well. So, Jasmine, I'll come back to you.
Yes,
You
ma'am.
said in your history that why did you ask for history of loose and neck pathology?
Sorry, ma'am.
Why did you ask in your history about loose teeth and neck pathology?
Yes, ma'am. Neck pathology, loose teeth, etc. Because of the positioning for bronchoscopy, ma'am.
You were trying because you were suspecting in your history that what is the position for bronchoscopy?
Um, Sniffing the question, ma'am.
What is sniffing position? So
Ma'am,
you are supposed to say that during rigid bronchoscopy, the neck has to be flexed and head has to be extended on the neck.
yes, ma'am.
And if it is not possible to extend the neck or there is a contracture neck or a restricted neck, then rigid bronchoscopy may not be possible at all, right?
Yes.
And another
Yes, ma'am.
thing that you want to see is that whether a child has a difficult airway. All
Yes,
these
ma'am.
things, loose teeth, buck teeth, any pathology of the face, neck, etc. Sometimes child may not show you mouth opening on examination. You may have to ask the parent in history itself कि इसका मुंह पूरा खुलता है क्या? इसका कोई दांत तो नहीं हिल रहा है, right? It's all
Yes,
part
ma'am.
of history.
Yes,
And
ma'am.
did you ask the last meal time?
Yes, ma'am. It was 12 hours back, ma'am. The same thing. He was having peanut, ma'am.
Okay. And why did you ask for history of allergies and asthma? That we have already explained because child may have these things in the past. You ask
Yes,
for
ma'am.
you ask for history of fever as well. Okay. Last
Yes,
meal
ma'am.
time is important. Why Arvindan? Why last meal time is important to us? Arvindan, can you hear me, Jasmine?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay, Arvind, why last meal time is important in this case or in any case?
Ma'am,
Why did you ask?
risk of aspiration is there, ma'am, if adequate NPO is not there.
This? So would you suppose? Okay, we'll go on to that next. Jasmine, you can continue with examination. Okay,
Yes, ma'am.
Jasmine, one more thing.
Yes,
So,
ma'am.
why did you not ask for any history of dysphagia or some
I had
problem in
asked
swallowing?
feeding, ma'am. Yes,
Why
ma'am.
did you ask? Why did you ask?
There can be a case
To
of
say
foreign body and esophagus also, ma'am. Or
do what? For stuffing?
sorry, ma'am.
Child is, are you asking in this case a foreign body in esophagus
It
can
can
be
go,
present,
ma'am. There can be
but
a foreign
often
esophagus or the foreign body can be obstructing. If it's at laryngeal level, it can obstruct the esophagus also, ma'am. So there will be.
and vice versa also. A foreign
Yes, ma'am.
body present in esophagus, if it is large enough, it can compress onto the
It
trachea
can
and cause
compress on the
airway.
airway, ma'am.
Trachea and, or the larynx and cause airway symptoms.
Yes,
Generally,
ma'am.
we take that history as well. So we should know why we are taking this history. Okay, let's
Yes,
go
ma'am.
on to the examination.
Yes, ma'am. General physical examination. My patient is 6-year-old male child who is alert, conscious to time, place, and person, normally nourished, obeying commands, sitting comfortably on the bed. His height is 115
Wait here,
centimeter.
wait here. Okay, continue.
Height is 115 centimeter. Weight is 20 kgs. His physical growth matches his age. Vitals. Patient is afebrile to touch. Pulse rate is 98 beats per minute in left radial artery. Regular rhythm. Normal volume. Normal character. No radial or radiofemoral delay. All peripheral pulses felt. Respiratory rate is 20 breaths per minute. Thoracic in nature. Regular rhythm. Nasal flaring, suprasternal, intercostal, subcostal retractions are absent. No adventitious sounds are heard. BP is 96 by 62 millimeter of mercury in right arm in supine position.
You are saying no adventitious sounds are heard.
Ma'am,
What do you mean by that?
I was trying to rule out stridor, ma'am.
Why don't you say no stride out?
No stridor
It's
present.
an examination, huh? Here you can use your scientific terms.
Yes, ma'am.
I'm not clear why are you saying that no adventitious? What do you mean by adventitious? Anything you have to specify.
Okay, ma'am.
Okay.
Uh, Capillary filling time is less than 3 seconds. Saturation is 98% on room air. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema is present. Head-to-toe examination, no abnormalities were detected. No signs of nutritional deficiency were seen. No signs of dysmorphism or congenital abnormalities were seen. Starting with airway assessment, no abnormalities were detected in face, head, neck, and chin. Bilateral nasal patency was seen. Mouth opening was more than 3 fingers. There were no loose tooth present. There were no abnormalities of chin seen. Interdental distance was 40 millimeter. Uvula was completely seen on mouth opening. The range of neck movements were normal, within normal range. According to Cooper score, Cooper scoring was 6, which was equivalent to EC intubation. Ma'am.
Great, sir. Great, sir. Ashwini. Harini. Harini, Dr. Bhandi, can you unmute yourself?
Yes, ma'am. Good evening.
Yes, good evening. Can you tell me how you will examine an airway of a child?
Ma'am, for a
Yeah, he's a 6-year-old or 4-year-old child. Previously, she said 4-year-old. Now she's saying 6-year-old.
ma'am, Cooper
Let us
scoring.
assume he's a copule, right? What is the full form of copule?
Ma'am, I'm not able to hear you.
What is the full form of copule?
Ma'am, chin, opening of mouth, then previous intubation ka history,
An OSA?
OSA.
An OSA. So it's for uvula. It is equivalent to Mallampati classification that we do in adults. R is for range of movement of the neck. It is actually called Colorado airway score. So, I just added it here so that everyone is familiar with it. It is not very common thing. Not many books are giving it. So you should all be aware of this copule scoring.
Okay, ma'am.
So,
Okay, ma'am.
but see, here the child is 6-year-old or a 4-year-old and is cooperative, so you are able to examine all this. But suppose the child is 2-year-old, will not allow you mouth opening probably. Okay. So
Yeah,
otherwise, if the child is not cooperative, how and is a smaller child, how do you examine for the airway?
That I don't.
Huh? What are you saying? You know, head-to-toe examination में क्या देखते हो? Whenever, just imagine yourself being posted in plastic OT, and there's a child there. What do you examine? How do you look at the child?
Ma'am, we can see the mouth opening while crying.
Yeah, you can ask the parent as well. And okay, crying में देख सकते हैं बिल्कुल. Neck movements you can always do. Passively you can move the neck and see. Then
Nasal
facial
pattern.
deformity. सबसे पहले तो you can look at the patient and see. Chin में क्या देखते हो? Recessive है, hypoplastic है ना? Length of the neck देख सकते हो. Any congenital anomaly associated देख सकते हो. Which is a deformity of the face, neck and head. वो माइलोसील है, जैसे अगर वो नहीं है, कुछ भी देखोगे तो you basically was trying to see नेक की लेंथ आप ऐसे ही ऑब्जर्व कर सकते हो. शॉर्ट नेक है, ऐसे देख सकते हैं ना. So head to toe में you can see loose teeth, buck teeth. Smaller baby may or may not have a loose or buck teeth. This is how you examine. So if you can do copule, well and good. If you can't, then you can just look for any abnormalities.
Okay.
Okay. Okay, Jasmine, go ahead.
Yes, ma'am. Respiratory system examination. On inspection, chest appears normal in shape. No scar marks, swellings, or color changes are seen. Bilaterally symmetrical movements were seen on respiration. Trachea is central, not deviated. Respiratory movements are thoracic in nature, not associated with nasal flaring, suprasternal, subcostal, or intercostal retractions. On palpation, trachea appears central, not deviated. There are no tender areas. Chest expansion is bilaterally symmetrical. Tactile vocal fremitus shows bilaterally symmetrical observation on both anterior and posterior side. On auscultation, bilateral air entry is present and it is equal on both sides. Vesical breath sounds are heard on both sides. And wheeze is present on right side during inspiration and expiration.
So from your examination, can you define your diagnosis now?
Ma'am, the only finding during respiratory system examination is wheeze present on right side during inspiration and expiration. That is pointing towards foreign body at bronchial
On
level.
the right, or be on the right side on the bronchi.
Right bronchus, ma'am.
So, luckily, this child which we have presented is very cooperative, not having any respiratory distress. But can you tell me what else could have been we could have found out on an examination had the child been younger and in respiratory distress?
We would have seen
Class of fasting is over. You would like to take up. Okay,
Yes, ma'am.
you have to keep that in mind, and this will be asked to exams. Always they will be asking you. Okay, Jairam, now we go on to the, since you people may not have seen rigid bronchoscope or this case before, Jairam will explain to you the various parts of rigid bronchoscope to you. Over to you, Jairam.
Yes, ma'am. So, ma'am, rigid bronchoscopy. Rigid bronchoscopy is a surgical technique that is used to visualize the oropharynx, larynx, vocal cords, trachea, and the proximal pulmonary branches. So, I will be describing regarding the instruments first. So, the image, you can see the image in the slides. That's the position of you hold while describing the bronchoscope. So bronchoscope, it has got two ends. One is distal end, another one is proximal end. Distal end is beveled and tapered, and this end is used for the through this end only we will insert into the trachea. And there is a small holes in the distal end which is for the ventilation purpose, especially ventilating for the opposite lung, to ventilate the opposite lung. So coming to the proximal end has got like many ports for the different purpose. One is superior port. Superior port is for the light source, and inferior port for the ventilation purpose. This is the port where we attach the circuit, anesthesia circuit. Then central inline port, the main one is there's a one bigger working channel that is for the instrumentation purpose and to insert the telescope also, and there is a one side smaller port also for the suction purpose.
And this smaller port can also be used to attach jet ventilation cannula.
Yes, ma'am. Jet ventilation cannula can also be inserted in that small port. Then now and this second image showing the different sizes for a particular age group of the and then in the right side image you can see the telescope. The black color is nothing but say eyepiece, and there is a port for the light source also in the telescope. And then this is the image again showing telescope inside the bronchoscope, and there's a one inferior port for the ventilation purpose and superior port for the light source, and again side port for the suction catheter. And there are different sizes are available for a particular age group, and the size of the bronchoscope is like 0.5 millimeter bronchoscope. Plus or minus 0.5 size should be ready before the bronchoscopy. Ma'am, indication and contraindication?
No, just was the procedure.
Okay, ma'am.
That you showed.
Okay, ma'am. So here, this image shows that how during ventilation how the gases flow occurs. So from the ventilating port, and first there is a narrow space in between the telescope and the bronchoscope. So and ventilation is occurs through that narrow space only, as you can see in the images. And in this case, telescope and bronchoscope is present in the right bronchus, and the side walls is ventilating the opposite lung, left bronchus.
No, we don't want this. Come back to the previous picture, please.
Yes, ma'am.
Back to the previous picture. No, the picture. Oh, the mechanism of respiration which you was.
Ma'am, 1 second.
And the color, the hand
Ma'am, this
drawn
one.
picture. Right, right. So, procedure of bronchoscope we have to understand here, which is bronchoscope is generally of the size of the endotracheal tube, which we are going to insert into a child. So a child which needs a 3 millimeter internal diameter will probably be the same size bronchoscope will be used. But since there can be airway edema and the ENT person may have to go into a bronchus for a distal foreign body into the smaller bronchioles, we need to have various small size bronchoscopes as well. Normally, the proximal end of the bronchoscope is open, which is the main working channel through which we are going to insert our telescope, which views the foreign body of which gives us, and this telescope jo hota hai na, on the proximal end there's an eyepiece on which we can attach a camera, similar to the fiber optic. Just imagine your fiber optic bronchoscope. There's a proximal eyepiece to which we attach a camera. The telescope is similar to that. There's an eyepiece to which we attach a camera, and then we can visualize everything that the telescope is seeing onto the TV screen. Nowadays, because of this facility, we can see what surgeon is seeing. Right. So that is a very good thing. And another important thing is that this telescope has viewing angles because of certain prisms or whatever they are inside it. So it has probably 30-degree telescopes are there, 70-degree viewing and 90-degree viewing telescopes are there. So if there's a foreign body in an upper bronchus or a middle bronchus, bronchoscope cannot go inside that. Your telescope can view those kind of foreign bodies lodged in these places as well because of their viewing angles of 30, 70, and 90 degrees. Then another important thing is that the respiration is occurring from the side arm of the bronchoscope between the outer wall of the telescope and the inner wall of the bronchoscope. So if the bronchoscope size is very small as that we have to use in the smaller children, the resistance to ventilation, which is already high, becomes even higher in smaller children. So when resistance to ventilation is high, what is the problem? Somebody tell me. I'll ask Gautam. Tell me what is the problem when the resistance is high to breathing? What will happen?
Good evening.
Gautam there?
Good evening, ma'am.
Good evening.
What
will happen?
Can you just repeat the question?
saying-
What voice was?
Yeah, the question is that patient is breathing between the outer wall of telescope and the inner wall of bronchoscope, which is a very narrow
Yes,
space. So there's going to be a
Yes,
very
ma'am.
increased resistance to breathing, whether it is
Yes,
spontaneous
ma'am.
breathing or whether it is an IPPV. So what are the considerations because of this? What problems can we have because of this?
Ma'am, if the patient is already anesthetized and we are giving IPPV for the patient, because of the increased sessions, the foreign body can further dislodge deeper into the bronchus, ma'am. That is one of the concerns we should be
we are
kept in
not
mind.
talking about this. Even if the resistance is high in the spontaneous, what will happen? There's no IPPV.
If
then what will happen?
if the resistance is very high when the spontaneously breathing patient, then instead of since the patient is not able to draw in the air, patient if he is giving tremendous amount of effort, he might eventually land up in negative pressure pulmonary edema if the pressure is very high, ma'am.
Resistance high में pulmonary edema हो जाता है. Imagine करो
No, like
हमारे
I'm
patient को bronchospasm हो गया, resistance high होगी,
Yes, ma'am.
bronchospasm हो गया, तो उसको inspiration में problem होगी कि expiration में problem होगी?
expiration में बहुत प्रॉब्लम हो जाएगी, मैम.
ज्यादा problem expiration में होती है ना?
Yes,
क्या
ma'am.
होगा
Yes, ma'am.
जब bronchospasm हो जाएगा या resistance बढ़ जाएगी तो hypocardia होएगा patient को, airflow है ना? You
Yes, ma'am. Yes,
understand?
ma'am. Yes,
There
ma'am.
is
Yes, ma'am.
increased airflow, there is increased resistance to the airflow. So both during inspiration and expiration, so there can be inadequate ventilation to the child, there can be hypocarbia, there can be hypoxia as well. Then there
Yes,
is
ma'am.
increased resistance to the respiration. What our respiratory rate should be and what our time of expiration should be.
Ma'am, usually the inspiration and expiration ratio we keep it as 1:2, ma'am, at the least. Like the expiration phase will be twice
I
the
am saying
inspiration.
when there is resistance to breathing, should we not think that there is resistance to expiration? Then our
Yes, ma'am.
expiratory time should be sufficient so that there is enough time for the expiration to
CO2
occur.
to yes, ma'am. If there is any
So
resistance, we should
we are
increase
going
the
to keep
expiratory
our
time.
we will increase our expiratory time, or if not that,
Yes,
we are going to give sufficient expiratory time, keeping our respiratory rates low.
yes,
Yes.
ma'am. Yes,
So
ma'am.
this is one of
Yes,
our important considerations while we are ventilating a patient with a
yes, yes, ma'am.
telescope inside the bronchoscope. This is when the
Yes, ma'am.
telescope is inside the bronchoscope and the resistance is high. But
Okay,
when we
ma'am.
are ventilating a patient without the telescope inside, resistance may not be high. So that time
Yes, ma'am.
we are doing that, then we sometimes have to ask the surgeon for the telescope because the patient is having hypocarbia or hypoxia.
Oh.
Once the telescope is out, we can hyperventilate the patient and we can ventilate the patient well, because now the whole bronchoscope inside area is available for
Available
ventilation.
for us. The
Correct?
resistance is yes, ma'am. Yes,
Density
yes,
will
ma'am.
be low, so we can ventilate and hyperventilate the patient and allow the
Yes,
CO2 to be removed if such
for sure.
condition
Yes,
occurs,
ma'am.
right? Or if a
Yes.
telescope, so that is what I'm trying to explain to you, the mechanism that what we are having. Another thing
Okay,
with
ma'am.
bronchoscope is that the proximal end, which is our main working channel, is open to air, right?
Yes, ma'am. Yes,
Whatever
ma'am.
we are trying to give to the patient, suppose we are giving IPPV to the patient, what are
Yes, ma'am.
we are giving to the patient?
We'll be
Most of it
giving
will
both
also go
inhalational
out of
and
the
oxygen coming to
air.
the
Yeah.
proximal end, which is open to the air. So we can also contaminate the environment also, ma'am.
Environment contamination, I'm least bothered. I'm more bothered that I'm giving a positive pressure bed and through the path of least resistance, most of it is going out of the bronchoscope and not into the
Yes,
patient's
ma'am.
lungs. I'm more
Okay,
concerned
ma'am.
about that, right?
Yes, ma'am.
We need to, when we are, suppose there is hypocarbia occurring or hypoxia occurring, we need to ask the surgeon to stop the instrumentation, remove the instruments and close the proximal end of the bronchoscope with either his thumb, or then there are sliding eyepiece and blocker on the bronchoscope. You can go there and see. There's a sliding thing
Yes,
on the
ma'am.
proximal end which can be attached to the proximal end. They can put up eyepiece slide and eyepiece can come onto the bronchoscope and stop the block the open end of the bronchoscope main channel.
Okay.
Correct?
Okay.
So
Okay.
that can be done. Or as previously explained, remove the telescope, bring the proximal end of the bronchoscope back into the trachea from the bronchi and ventilate both the lungs to prevent this hypocarbia and hypoxia which can occur.
Yes, ma'am.
Understand?
Yes, ma'am.
Anybody who's not understood and would like me to explain again, please, they can come up because this is the most important part of this whole lecture. This you have to understand. It will not be given very clearly in most of the books. It is practical thing. So anybody who's not understood what I just explained, can ask me to, I can explain again. Anyone? Think again. I'm taking a pause here. Okay. So I understand
Hi.
this.
Good evening, ma'am. Ma'am, I am Rajeshwari, ma'am.
Okay, Rajeshwari, tell me
Ma'am,
what
can you please explain why we want to close that bronchoscope, proximal end of the bronchoscope, ma'am?
whenever we are giving an IPPV, we are giving something with positive pressure. We're pushing the air with positive pressure to the lungs.
Yes, ma'am.
Positive pressure में क्या होगा अगर system close नहीं है तो your tidal volume will go through the path of least resistance to the outside from the proximal end, right?
Yes,
And
ma'am.
less will go to the patient, which is at the
Yes.
distal end. That's why we want to close the system but that may not be possible while we are doing instrumentation. And also, understand,
Yes, ma'am.
because through the main working channel, which is the central channel of the bronchoscope, we are also putting the instruments inside. So we can ask the surgeon, the hypoxia, hypocarbia ho raha hai, we can ask the surgeon to draw the instruments, telescope and the grasping optical forceps out, close the proximal end and we can ventilate the patient. And this is also the reason that we have to give higher flows to the patient. And this is
Okay.
also the reason that we are using 100% oxygen with the inhalational agent while ventilating the patient. Okay. We
Yes,
do
ma'am.
not use nitrous oxide in these cases because as it is, the patient may have compromised lungs. There's an obstruction to the airway. They're prone to hypoxia. And nitrous oxide will also may go into the hyperinflated lungs and cause further hyperinflation of those lungs and cause alveolar rupture and pneumothorax and pneumomediastinus can occur. So I hope everybody has understood this main part. We'll further elaborate on it while we are considering the anesthesia. So now we have understood that it's an urgent procedure, not an emergency procedure, unless there are certain conditions like severe respiratory distress or a laryngotracheal boring, or there's a risk of progression to the complete airway obstruction. Now, we come to the, what is your plan of anesthesia, Jairam, in this case?
Ma'am, in this case, under general anesthesia with inhalational agents and IV induction agents, and I'm going with controlled ventilations with relaxants, ma'am.
Okay, very good. So now we can talk. Before there are other methods of doing this case as well. But in exam, what we are doing in our operation theater is something which you have to say always, unless asked that what are the other methods. We'll discuss them later. But now we should concentrate on what and how we do it routinely in our operation theaters. This is the technique which Jairam just said, that we can use spontaneous ventilation also, we can use jet ventilation also, we can use apneic insufflation also, but earlier we used to use, but these are not required now. We'll discuss pros and cons of these later, but let us discuss what has to be done and what are the anesthetic considerations when we are giving general anesthesia to the patient with IPTV. So let's see who's there. Nisha Ravi Kumar. Nisha.
Hello. Good evening, ma'am.
Good evening, Nisha. Can you tell me what are the anesthetic considerations in this case?
Ma'am, in this, ma'am, mainly considerations.
You can also consider patients who are in respiratory distress or who have some compromise of the lungs, and say we can take the age to be say 2 years.
Yes, ma'am. Ma'am, we can divide the considerations into patient factors, surgical factors, and anesthetic factors, ma'am. And the patient factors,
So
ma'am.
you tell me, yeah. First, you tell me only patient factors.
Yes, ma'am. In patient factor, ma'am, mainly we'll be dealing with the pediatric age group, ma'am. So the concern here will be will pediatric age group. So we should maintain. We should not have patient should not have hypothermia. We should maintain adequate temperature regulation should be there, ma'am, and IV cannulation should be looked for, ma'am, after induction, or we should decide the plan before, ma'am. If there is no
wait here, beta, wait here. So I'm giving you a condition. Patient is a 2-year-old child with some respiratory distress. Okay, some amount, probably mild respiratory distress. You rightly said that we have to have a pediatric age group considered. But now
Yes,
this patient, before you go on to temperature and other things, you should talk more important things here, right? So we can say that patient is anxious, probably uncooperative, and in mild respiratory distress. So that is a consideration to us, right?
Yes, ma'am. Yes, ma'am.
Can you tell us why we need to keep the child calm? We don't want the child to cry.
Ma'am, if the child starts to cry, ma'am, more chances of hypoxia and cyanosis and leading respiratory distress might increase, ma'am. So it is better the
Very
patient.
good, very good. Okay, very nice. And also the crying can dislodge the foreign body and make a partial obstruction into a complete obstruction. Fine.
Yes, ma'am.
Okay.
Yes.
So the consideration here is that we have to make rapport with the child. We need to keep an anxious, uncooperative child calm who's already in some respiratory distress so that the distress does not increase. Now, second important point that you said that IV induction, IV cannula has to be put. Now, in this case, we will not put an IV cannula after induction. Here, it is a very risky case that we can lose the airway, and we may need to give certain free medicines before we start the case, which we will discuss later. So here, I would like to put the IV cannula before induction. So, how would an uncooperative and anxious child allow cannula without time? Can you explain somehow?
Ma'am, we can deviate the child's attention, and we can apply EMLA cream before cannulating the child.
How long before amla cream should be applied for its proper effect to come?
Ma'am, 15 to 20 minutes.
No, it is 45 minutes to 1 hour prior. So you have to plan. Okay. So you know that you're going to take up a case within a 1 hour. First thing that you would do is you would identify a vein, the hand
Yes.
of the child, while the child is sitting in the lap of a parent, and then try amla cream over there and put an occlusive dressing. Okay?
Yes.
And then you can give your, I put an IV line later. And one thing to keep the child is calm, you put parent ke lap mein rakho. Then second, you can distract him. Third, you can apply an amla cream which will not cause him pain. Sedation, I would not recommend because here you can lose an airway.
Yes,
Normal
ma'am.
children, we can always give oral midazolam or oral ketamine, but here it's a case where the upper airway may be obstructed or the lower airway. Upper airway obstruction is a more important cause. We generally don't like to give sedation to such cases where we feel that child respiratory distress of the child can increase because of obstruction of the upper airway as well. Okay,
Yes, ma'am.
so very good point. Then Neha Dwivedi, can you tell some other patient-related anesthesia concern pertaining to this case per se?
Hello, good evening, ma'am.
Neha?
Ma'am, patient-related factor.
Yeah.
Ma'am, pediatric age group, as Nisha has already said, pediatric age group में we are more concerned about we have to avoid like child respiratory distress. If child, we will separate the child from the parents. Definitely, child respiratory distress will be there.
हो गया बेटा.
Child
Child
is
का
not
parent. We are not going to give any sedation.
Ma'am,
We are
avoid
trying to avoid
sedation.
unless needed very badly. और क्या करोगे? और क्या
Ma'am,
concern है?
cannulation we have to
The
secure.
respiratory compromised patient है, more prone to hypoxia, and on top of that, the children have less oxygen reserve because of decreased FRC. They
Oxygen
have more
supplementary.
oxygen demand. That
Yes,
further predisposes to hypoxia especially during apnea when you paralyze the patient and your bronchoscope is out of the patient, or
yes,
when
ma'am.
the
We
resistance
have
is
to
high
avoid
or
sedating.
हाँ. So child का oxygen reserve कम है, oxygen demand ज़्यादा है, which predisposes to hypoxia. The child may be have a compromised respiratory compromise हो सकता है, which may again lead to hypoxia. Then another important thing is that there can be hyperreactive airway and airway edema present due to peanut, which can lead
Yes,
to
ma'am.
bronchospasm, laryngospasm,
Bronchospasm. Yes, ma'am.
है ना, in the child. Next we come to the anesthesia related considerations. So who will tell me? Dr. Megha. Megha PB. Can you tell me some anesthesia related considerations? Megha PB is there? Dr. Meghna KB. Dr. Meghna KB. Can you tell me some anesthesia related considerations? Okay, Dr. Mohammed Gayal. Mohammed Dayaz.
Hello, good evening, ma'am.
Hello, good evening, Mohammed. Can you tell me some anesthesia-related considerations? There are lots and lots.
Yes, ma'am, for 2-year-old baby,
I have
since we have
already
taken.
discussed few of them.
Hello, ma'am.
Mhm.
Hello.
Hello.
Am I audible?
Yes, you are audible.
Yes, ma'am. Since we have taken IV cannula in the beforehand, we will be inducing the patient with inhalation induction after that, and our consideration will be like inhalation induction followed by maintenance with IV and inhalation
No,
agent.
that's not a consideration. Considerations. One most important consideration that I've already discussed is that we are ventilating. We are sharing the airway with the surgeon. So
Yes,
we
ma'am.
need to
So
have a
we
very
have to be
close
in constant
communication with the
communication with
surgeon.
the surgeon.
The airway is not fully in our control. We are dependent on the surgeon's ventilating bronchoscope for
Yes, ma'am.
controlling the airway of the patient. That is one important anesthesia consideration, that we are
Yes,
sharing the
ma'am.
airway. We need to have close
The
communication,
constant communication with
with
the surgeon.
the surgeon. Secondly, we are ventilating through the side arm of the rigid bronchoscope. And I just discussed that it can lead to increased resistance to breathing, hypoxia, hypocarbia, and which can be dangerous, especially if there is already some respiratory compromise present. What we need to do here is we have to keep the respiratory rates low and allow sufficient time for passive exhalation to occur. Right?
Yes, ma'am. Yes, ma'am.
Anything else? What other thing? Don't want any hypoventilation or apnea to occur. So I discussed already that sometimes when you may have to ask the surgeon to remove the telescope, especially in a smaller child, so that we can ventilate the child the larger diameter of the bronchoscope rather than the small space between the telescope and the bronchoscope. Okay,
Yes, ma'am.
this is also one of
Yes,
the
ma'am. Okay.
anesthesia considerations. Then ask
Okay.
another thing that we discussed, that may have to ask the surgeon to pull the bronchoscope out of the bronchi, come back into the trachea so that you can ventilate both the lungs.
Okay.
Okay.
Yes, ma'am.
Another consideration related to the bronchus, that gas leak is occurring to the atmosphere, so we may have to use higher gas flows, right?
Okay, ma'am.
Other which I already discussed, which is very important, is that I have not discussed this. Can you tell me what we are doing an airway instrumentation in a patient? It's a very
Paroxysmation, ma'am.
stimulating surgery. So what our anesthesia should be like? The moment they are,
Yes, ma'am.
what would you
Other.
are doing a very stimulating surgery. We are doing airway instrumentation. So what anesthesia consideration do you think is there?
So depth of anesthesia should be maintained and analgesia should be given, and to decrease the inflammation, we would have given steroids in the beforehand.
So we have to maintain the deep plane of anesthesia
Yes, ma'am.
and proper muscle relaxation so that there is no what complication can occur if there's deep plane of anesthesia is not there. What we want to avoid.
Patient may come out of the relaxant. It may cause bronchospasm or laryngospasm.
Patient suppose is not out of the relaxant. Patient is only in the light plane of anesthesia. We are not able to ventilate the patient well. Nitrous oxide is already not there. We are just using 100% oxygen and inhalational agent, and somehow we are surgeon is taking out the bronchoscope outside a lot of times, opening the airway, and we are not able to maintain the deep plane of anesthesia. So what problems can we have besides hypoxia and hypercarbia? Any other problem that we can have because of light plane of anesthesia? In a paralyzed patient. माइक्रोलेरेंजल सर्जरी कराया है कभी? लाइट प्लेन ऑफ एनेस्थीसिया में एयरवे को क्या हो सकता है? एयरवे इंस्ट्रूमेंटेशन कर रहे हैं लाइट प्लेन ऑफ एनेस्थीसिया में, व्हाट कैन ऑकर? डॉक्टर राजेश्वरी, कैन यू आंसर? Dr. Rajeshwari?
Hello, ma'am.
I'm saying if there is a light train of anesthesia, what problem can occur while we are doing airway instrumentation? Patient is adequately paralyzed, but there is a light plane of anesthesia. What can happen? Yeah, a simple question is you have.
Hello. Hello.
कौन बोल रहा है? Yes, who's speaking?
मैम पंकज. मैम
जी,
पंकज.
पंकज जी.
मैम अगर लाइट प्लेन ऑफ एनेस्थीसिया होगा मैम, जब अगर हमने ब्रोंकोस्कोप डाल रखा है, अगर हमने फॉरेन बॉडी ग्रैप्स कर लिया है, अगर वोकल कॉर्ड मूव कर रही है, तो वो फॉरेन बॉडी फिर दोबारा से नीचे गिर जाएगी.
अरे पेशेंट फुल्ली पैरालाइज्ड है बेटा, vocal cord मूव ही नहीं कर रही. आई एम सेइंग देयर इज कंप्लीट मसल रिलैक्सेशन, देयर इज लाइट प्लेन ऑफ एनेस्थीसिया. Understand what I'm trying to say? Patient can have exaggerated airway reflexes, right? Can have vagal stimulation, can have vagal mediated bradycardia, he can have bronchospasm, can have other cardiac dysrhythmias because of airway obstruction. So you have to keep the plane deep, allow airway instrumentation. And if there is no proper muscle relaxation, then patient can have that problem that you were saying. Then at that time, patient can also cough and buck. With the bronchoscope inside, there can be tracheal perforation with the patient coughing and bucking. He's not properly relaxed. Understand what I'm trying to say? So you
Yes,
have to
ma'am.
maintain deep plane of anesthesia, to allow airway instrumentation, to upfront the airway reflexes which can cause bronchospasm, and to prevent the vagal mediated bradycardia and other cardiac dysrhythmias that can occur. And we also need to have proper muscle relaxation to prevent coughing and bucking, and also laryngospasm, which can occur with the vocal cord and vocal cord movement that can occur while we are taking out the foreign body. और इंट्रोप में तो ये हो गया. और क्या प्रॉब्लम हो सकती है? रिस्क ऑफ एस्पिरेशन हो सकता है, because bronchoscope में there is no cuff, so seal is not there as we have in a tube. There can be risk of aspiration. फिर पोस्ट-ऑप में क्या प्रॉब्लम हो सकती है? एनेस्थीसिया कंसिडरेशन पोस्ट-ऑप में कुछ प्रॉब्लम हो सकती है? Hyperreactive airway patient का surgeon has done bronchoscopy. There can be laryngospasm, immediate post-op laryngospasm, and bronchospasm can occur at the time of reversal. And there can be airway edema also around the larynx or subglottic region or in the bronchi. You have to nebulize the child, and you have to give steroids in the pre-operative period only. Okay. So can you tell me some surgery-related considerations, Jairam? What does
Hello,
the
ma'am.
surgeon want? Jairam, surgery-related considerations.
Surgery related considerations, like one is communication between the surgeon and anesthetist throughout the procedure, and while foreign body displacement भी हो सकते हैं while instrumentation, and there's a if foreign body displacement over the, it may result in the total obstruction also. Then while removing
Can we Jairam, can we
yes
speak
ma'am.
slowly? कहाँ पे foreign body displacement हो जाएगा?
Ma'am, it can distally, more distally it can displace, ma'am.
Foreign body bronchi की अगर और distally चले जाएगी, कैसे चले जाएगी?
Ma'am, if fragmentation हो गए तो then it can go into more distally.
Okay.
Then while removing,
what does surgeon want during the surgery?
ma'am, in this time surgeon was like deep plane of anesthesia and complete relaxation.
He wants an immobile surgical field.
Immobile surgical, yes.
And no time restriction during the procedure.
Yes, ma'am.
Yes.
And
so this is an overlap between a surgery and the anesthesia consideration. You can write it in
yes,
either. Okay.
Yes, ma'am.
Then during the retrieval of the foreign body can drop.
Yes, ma'am. It may stuck if the patient is spontaneously breathing. It may stuck out moving vocal cords. Then patient it can obstruct. It can cause total obstruction also in such cases.
So in that case, what should the surgeon do immediately?
Ma'am, if it causes total obstructions, one surgeon has to remove it immediately, or else he has to push the foreign body to the original location.
Original bronchus.
Yes, ma'am. Original bronchus.
Originally,
So,
originally blocked bronchus.
yes, ma'am.
What will happen if the foreign body goes into the contralateral bronchus?
It can cause total obstruction, ma'am, in such cases.
Right?
Yes, ma'am. Ma'am, already there is a
bronchus तो open है ना, पहले the previous वाला bronchus तो open है ना, फिर क्यों complete obstruction होगा?
ma'am, in chronic cases, it can cause, there is already edema and mucous plug in such cases.
Yes.
It can cause
If
chronic complete obstruction.
If the previous bronchus has lots of edema and inflammation and it is already blocked, then
Yes, ma'am.
if the contralateral foreign body drops into the contralateral, then only it will cause complete obstruction, not always.
Ma'am.
Right?
Yes, ma'am. Yes, ma'am.
So, और क्या
And
surgery
other consideration is like repeated instrumentation can cause airway edema, trauma, bleeding, and it can increase secretion. It all can obstruct their view, ma'am.
Very good. So we trauma to the airway, bleeding in the airway, post-op edema
Yes,
because
ma'am.
of repeated and also because of repeated suctioning done.
Yes,
Then
ma'am.
if the foreign body is too large, it is larger than the inner diameter of the bronchoscope.
Ma'am, if the hello, if the foreign body is small, they can remove it through the bronchoscope. If the foreign body is large, it cannot be removed through the bronchoscope. So they have to remove the foreign body entirely, like foreign body plus telescope plus bronchoscope all together as a single unit, ma'am. They have to remove
out
as a
of
single
the
unit.
vocal cord.
Yes,
Out
ma'am.
of the vocal cord. So at that time, what should be our consideration? What should we be doing? We should
Ma'am,
have, at that time,
complete relaxation.
yes, complete relaxation should be there. And even for some time, we should stop ventilating the patient so that
Yes, ma'am. We should,
even with IPTV, we can move the cords
yes, ma'am.
open and the pressure of the air.
Yes, ma'am.
So during that crucial time, we can stop our ventilation and patient should be kept in the deep plane of anesthesia and kept paralyzed. That the
Yes,
vocal
ma'am.
cords do not move and otherwise the foreign body can be dropped.
Yes, ma'am. It can be dropped.
Okay. Now these are more or less most of the considerations. So now suppose we are taking up this case for surgery. What all pre-operative planning and preparation you would do for taking up such a case?
Hello, ma'am.
Okay, I'll ask somebody else. Varsha, can you tell me what all pre-operative preparation and pre-operative planning, equipment, etc. would you prepare before taking up such a case?
Good evening, ma'am. Ma'am, we'll keep the pediatric airway cart ready in the OT, and we'll also keep lignocaine spray and all our emergency drugs should be ready, and we'll also keep opioid induction agent plus choline ready.
You don't have to speak all the drugs like that. Always say that we will keep all anesthesia drugs and emergency drugs ready.
Yes,
Why would you
ma'am.
like to keep choline ready, Vase?
Ma'am, in
You're
this
already
case,
paralyzing the patient.
ma'am, if there is a sudden laryngospasm, if it occurs while extubation, and then we have to break if we are not able to break the laryngospasm by other airway maneuvers like Larsen maneuver, then at the end we have to resort to choline.
Very good. If you can justify your answer, it's well and good. So first of all, we would like to first do some pre-operative planning. We all say that we are sharing the airway with the surgeon, so we must have pre-procedure planning of all our surgical and anesthetic techniques, right? So good communication and cooperation, not only with the surgeon anesthesiologist, but also with your technical assistant and your nurses should be there. Your whole team should be familiar with your initial plan, maintain the airway and adequate ventilation, and also your contingency plan. What can be your contingency plans? Suppose there is a complete airway obstruction, what will we do? Things like that. Or if the foreign body falls, here what are we going to do? Are we prepared with cricothyrotomy? Is the tracheostomy set ready? All these things we have to plan out, right? although it may not work in many cases. So another thing, would you like to keep an ICU bed ready?
Yes, ma'am. In case the patient develops, if we are not able to extubate the patient because there may be severe edema or
So there's always a possibility, right? So ICU bed has to be kept ready. Then your high risk informed consent should be taken from the parent, the guardian, right? So these are an experienced staff who's skilled in this bronchoscopic technique and who's experienced with managing this technique. Anesthesia and these patients should be available, right? So this is your part of pre-operative planning. Then the second planning is your equipment which is required. So you can say we can keep all our anesthesia equipment, difficult airway card, defibrillator also ready because cardiac arrest can occur. Anesthesia drugs, emergency drugs ready. Uh, keep your fiber optic bronchoscopes, flexible video endoscopes, picothyroid ready. Most importantly, what would you check the surgeon regarding equipment? What would you like to check the surgeon?
whether if there's a proper connection between the bronchoscope and our anesthesia circuit, and whether we are able to vent.
Very good, very good. So we should always check that. And also, although it is a job of a surgeon to choose a proper size bronchoscope and telescope, we should also check them. Because there can be airway edema, we should see what size surgeon is using. If he uses a larger size bronchoscope than is required, then what problem can we face during ventilation?
Larger size bronchoscope, it will be difficult to
larger size
negotiate.
bronchoscope अगर ले लिया है तो it can cause trauma to the airway structures. It can cause more edema because of handling, right?
Yes.
जैसे हम larger size tracheal tube अगर use कर लेते हैं तो patient को croup हो जाता है, vocal cord में trauma हो जाता है, and things like that. We should always consider. There can be some airway edema, so we should always check. And once you've induced the patient and the bronchoscope light is not working, surgeon has not checked it properly, so you also check. It is an added this thing, safety check. This is for the practical purposes.
Yes.
Always have smaller size tracheal tubes ready. You may have to intubate the patient at any time, right?
Yes, ma'am.
Because of some problem. Okay. Now we are going to take up this case. Before that, we've already said that pre-medication, हमने intravenous catheter लगा लिया है patient को. What all would you like to give to the patient? What all drugs? Anything else? Dr. Subhi Taneja. Subhi Taneja, are you there? Subhi Taneja, are you there? Dr. Satish. Dr. Satish?
Yes, ma'am. Hello. Yes, ma'am. Good evening, ma'am.
Tell me
Yes.
what all would you like to give to this patient before we take up?
Ma'am, the surgeon will be operating on the airway, ma'am. So it is like a short procedure, but still he is operating in the airway. So for short procedure.
No, I'm asking you just what all drugs do you like to give?
In the
pre-medication. We have not reached the OT yet.
Yes, ma'am.
We have not reached the OT yet.
Yes, ma'am.
I'm only
Pre-medication
asking
may yes, ma'am. For a full stomach patient, maybe full stomach, ma'am. So injection.
It's not full stomach.
Okay. Then
full stomach
yes,
is the least of my concern. We are not taking a full stomach.
Ma'am, it's a pediatric case, ma'am. So for sedation, we can give pedicloral syrup, ma'am.
Satish, I couldn't hear you. What are you saying?
Ma'am, for sedation for the patient, we can give pedicloral syrup 30 mg per kg.
Why are we giving sedation to a patient? I just said that I don't want for the upper airway obstruction compromising a respiratory compromised child.
Yes, yes, ma'am.
I would prefer not to give. Although books say that we can give some amount of sedation to a child, but we would prefer not to give. Because it can cause complete airway obstruction.
Ma'am, then
Let's go ahead. What else?
Glycopyrrolate for decreased secretion, ma'am. For decreasing the secretions, we can give
What
glycopyrrolate,
else
ma'am.
glycopyrrolate help us with?
Ma'am?
What is another use of glycopyrrolate in this case besides decreasing secretions?
Ma'am, because of foreign body, there might be vagal stimulation, ma'am.
Ish, I can't hear you properly. Please.
Hello, ma'am. Ma'am, hello. Hello.
Bolo.
Ma'am,
Yes.
because of foreign body, there might be like vagal stimulation, bradycardia will be there, ma'am. So we can give
Yes.
by
We
giving
are doing, I
glycopyrrolate.
already said we are doing airway instrumentation, which is vagal-induced bradycardia can occur, right? So vagal mediated bradycardia can be prevented by glycopyrrolate. Also, vagal parasympathetic mediated reflex bronchoconstriction that can occur during airway manipulation. Suppose your plane of anesthesia becomes slightly lighter. This glycopyrrolate will also prevent that. There are three main uses: reduce the airway secretions, reduce the vagal mediated bradycardia due to insertion of bronchoscope and airway instrumentation, and also blockade of reflex bronchoconstriction that can occur during airway manipulation. Okay, you will be asked these questions. That's why I'm repeating it. Then what else? Gautam said he would like to give a steroid. Which steroid would you like to give for airway
Ma'am, I
edema?
would like to give dexamethasone.
What dose?
0.1 mg per kg.
0.5.
0.1, ma'am. 0.1 mg per kg. Yes, ma'am.
See, the normal dose is 0.1 milligram per kg. But here, in these cases, we give a higher dose to decrease airway edema and stridor, etc., which can occur post-op. So those variations have been given from 0.25 to up to 1 milligram per kg can be given to the child. So normally, chalo, we can compromise. So we'll give, say, probably 0.25 or 0.4 milligram per kg body weight of IV dexamethasone. So it would help us with decreasing the airway edema and stridor post-operative treatment. And it will also help us with other things like vomiting, pain, etc., etc.
Yes, ma'am.
Which are the, but we are talking here pertaining to this case. So, would you, if there's some pneumonia or any infective physiology present, we can give IV antibiotics also. And also, if the patient is having bronchospasm, would you like to nebulize the patient with a bronchodilator? Or anyway, we can nebulize the patient with salbutamol. Decrease the underlying hyperreactive airway, etc., which will be present in the presence
Reactive
of foreign body.
because of foreign body, reactive airway will come.
Yes. Okay. And suppose the patient is full stomach, as you said, then we can also give patient Zantac and Perinom. Okay. Yes, next. So we are taking the patient inside the operation theater. So, now we have attached our various monitors. I'm going to ask you what all monitoring you would. It's a small child. So जो normal pediatric precautions हैं, child के temperature maintain करना है, OT का, patient को cotton लपेटना है, conduction, convection, radiation से heat loss वगैरह जो हटाना है वो सब करोगे, ठीक है? So I'm not covering that here.
Yes.
Now we have already said that we would take the patient under GA with IPPB, and other techniques that are present we would discuss later. Now you have to induce this child. How would you plan to, doctor, how would you start your anesthesia? You've taken the child, you've attached the monitors. What all now would you like to? I would like to listen to the anesthesia steps now.
Yes, ma'am.
Samriti. Dr. Samriti.
Good evening, ma'am.
Good evening, Samriti. You say now, how will you start your anesthesia?
Ma'am, I will start by first pre-oxygenating the child with 100% oxygen.
Very good.
Then I will give IV opioid. I will give injection fentanyl with a dose of.
Whenever you're speaking, you should always say the route and the dose.
Ma'am, I will give injection fentanyl 2 microgram per kg body weight, and then I will use the inducing aid. Yes.
Yes,
Yes, ma'am.
Also.
Yes, ma'am. And ma'am, my choice of induction agent will be propofol. I will give injection propofol. Uh,
Why not inhalational anesthesia?
Ma'am, we have already secured IV line for this patient, so I will prefer IV induction.
Okay. IV induction किया with propofol, then propofol का again you have to specify how you will use the patient, what dose, what route.
Ma'am, I will give injection propofol 2 milligram per kg body weight. Uh, Ma'am, I will give in a titrated dose up to the
Titrated to
loss of
what?
verb. Ma'am, up to the dose of
Verbal
loss of
response.
verbal response.
Loss of response to a verbal stimuli or loss of a verbal response. ठीक है.
Yes, ma'am.
Then?
Ma'am, then after check ventilating the patient, I will give the muscle relaxant. Ma'am, as
And your flows are 100% oxygen and
ma'am, 100% oxygen with nitrous oxide and sevoflurane I will use in
you
inhalation.
want to give nitrous oxide. I already said that we would not like to give nitrous oxide in this case. Can you tell me why we would avoid nitrous oxide in this case? Nitrous oxide should not be given. I'm telling you it is not to be given. Can you tell me why? See, the patient is
because there
already
isn't
compromised, he's prone to hypoxia, and there can be hypoventilation during the procedure. So we would like to give 100% oxygen to the child and not compromise on oxygen FiO2, right? Also, I said that the patient can be having hyperinflation of the lung because of airway obstruction, check valve obstruction. So this nitrous oxide can go into that trap there and further cause more hyperinflation. And this hyperinflation can cause alveolar rupture, diastolic shift. The diastolic shift can and this alveolar can compromise the vascular cardiac output as well by pressing onto the heart, etc. Right? So we don't want that to occur. So we generally do not want to give nitrous oxide. So we would use only 100% oxygen along with an inhalational agent. Okay, so you've given a muscle. Now you want to give a muscle relaxant. Which muscle relaxant and what dose? That is not very important to us, but still you can say since you're speaking in steps.
Ma'am, I will use this is a 2-year-old child. I will use vecuronium with dose 1.1 mg per kg body weight. Ma'am, as this is not a case of respiratory distress, the patient there is
Even if there's respiratory distress, you would go ahead with this technique only.
Ma'am, if there is respiratory
distress, for mild respiratory distress.
Yes, ma'am. Ma'am, I will go with vecuronium only.
Okay, you've given vecuronium. Now what you will do? You will ventilate the patient for 3 minutes.
Yes, ma'am. Ma'am, then I will
do.
Ma'am, then we will have to hand over the patient to the surgeons for introduction of bronchoscope.
Excellent. That is what I was trying to see, whether you will say that or whether you would put an endotracheal tube into the patient. That is called presence of mind when you are answering your questions in the exam. So why somebody would you not prefer to put an endotracheal tube?
Sorry, ma'am.
Why would you not put an endotracheal tube and hand over the patient to the surgeon for insertion of bronchoscope?
Ma'am, because ma'am, surgeons.
Your endotracheal tube can push the foreign bodies. Some foreign bodies lying in the tracheal region, also it can push it down, and cause complete obstruction. And then there's no need because surgeon can you're anyway going to put a bronchoscope inside, and we are going to ventilate through that. So why put an endotracheal tube and cause more trauma to the airway? Right?
Yes, ma'am.
Okay, that's very good. So now, once you can we
Ma'am,
also
but
use inhalational? Suppose can we also use an inhalational induction?
ma'am, we can also use inhalational induction, and the choice of
Using what?
inhalational induction will be sevoflurane.
Right?
Uh,
Why sevoflurane and why not defibrillane? Why not isoflurane?
Ma'am, sevoflurane is ma'am, it is non-irritant, and there are therefore
The
there are
airway,
less chances of
non-irritant to the
air.
airway, right? That's why we want to use, and it induces fast. Earlier, what inhalation agent we were using earlier before sevoflurane was introduced? In
Ma'am,
these children
halothane.
with inhalation, halothane. Halothane का क्या problem है ऐसे केस में? हाइपोवेंटिलेशन हो रहा है, हाइपोकार्डिया हो रहा है, सेंसिटाइज मायोकार्डियम. हाइपोकार्डिया में हेलोथेन ज्यादा सेंसिटाइज करता है मायोकार्डियम टू द
Yes, ma'am. The patient will be more prone to arrhythmias.
हाँ, more prone to arrhythmias. ठीक है, and here already the patient can have arrhythmias. They are not able to maintain the anesthesia or ventilate him properly. So another problem with inhalation induction in these cases where there is an airflow obstruction is that the inhalation induction can be very slow because airflow कम हो रहा है ना? It
Yes,
takes
ma'am.
more time. And also there can be ventilation perfusion mismatch because of presence of atelectasis, etc. So the inhalation induction can be slower in these cases.
Yes, ma'am.
So what else? What else after we've given to the patient? What else surgeon does? How surgeon in what is the position of the patient? Okay, next person. Sakshi, are you there, Sakshi? Sakshi.
Yes, ma'am.
Okay, Sakshi. Have you seen foreign body bronchoscopy being done for the rigid bronchoscopy? Have you seen a case being done?
No, ma'am.
No, ma'am. Okay. Who has seen? Dr. Poonam, have you seen Poonam Chauhan?
Ma'am, but
Ma'am?
no.
Can you tell me what is the position of the patient while the
Ma'am,
surgeon, how the surgeon introduces
the patient
the
will have
bronchoscope?
the position in head elevated 10 to 15 centimeter by a pillow under the occiput, and the head will be extended at the atlanto-occiput joint.
Or have you
Ma'am,
actually seen a surgeon putting the 15 centimeter pillow?
No, ma'am.
हाँ? On the
No.
किसी book में लिखा है barking dog position where neck is flexed with
Yes, ma'am.
and then head extended. But normally we would go by a sniffing position only. Okay? Sniffing
Yes, ma'am.
position जो हम laryngoscopy के लिए करते हैं, the surgeon introduces a rigid bronchoscope using a laryngoscope. So that once he introduces the laryngoscope in sniffing position, he, under the vision of the laryngoscope, the rigid bronchoscope inside most of the time. Okay, they can put rigid bronchoscope otherwise also, but generally they use our direct laryngoscope version of rigid bronchoscope. And the position is mainly you bring the in position in older children, and in the younger children, you have to put the child in a neutral position such that the external oblique meatus is in line with the suprasternal notch. For example, in infants, etc. And okay,
Yes, ma'am.
that is your position. All three axes in one line. Then surgeon may introduce earlier bronchoscope into the patient's in trachea. Now what? Now what will we do? She continue.
Ma'am, we'll connect the breathing system to the side arm of the bronchoscope, rigid bronchoscope.
Very good.
And
Very
we will
good.
continue ventilating the patient through that.
Okay. So one step we missed here. Normally surgeons, what they would do is that they would spray the vocal cord before introducing
Yes,
their
ma'am.
bronchoscope.
LA
Spray
spray.
the
Yes,
cord with a 1 to 2% lignocaine. Okay. So can you
Yes,
tell
ma'am.
me what is the advantage of using this, spraying the cords and trachea with 1 to 2% lignocaine?
Ma'am, it will reduce the reactivity of the airway to, matlab, it will not be as irritated by the introduction of a rigid bronchoscope. And ma'am, there will be
Irritation से क्या होता है? Irritation से क्या होता है?
Ma'am, bronchospasm.
Yes.
And ma'am, airway reactivity.
Light comes
Yes,
out of
ma'am.
the
Ma'am, the vocal cords
the muscle
won't
vessel,
move
so
it if.
it will decrease the cupping and bucking on the bronchoscope.
Yes, ma'am.
It will prevent the laryngospasm in the postnatal period, and it will also decrease the requirement of the anesthetic agents which are required to maintain the deep plane of anesthesia.
Yes,
Right?
ma'am.
So topical anesthesia, these very important advantages. Okay. So now we are maintaining the patient on ventilating bronchoscope using IPPV. Can you tell me what your flows would be at this time? What else can be used to maintain this deep plane of anesthesia during IPPV? Next person, Dr. Rishabh Sharma. Rishabh, are you there? Rishabh? Rishabh is not there. Meghna, are you there? Vasav, Raj? Dr. KJ Kanya? Dr. Kanya? Dr. Kanya, are you there?
Yes, ma'am.
Okay. I'm
Hello.
asking
Hello,
you
yes, ma'am.
what, while maintaining the anesthesia, what would be your flows and what other drugs you like? See, our anesthesia requirement is that we have to maintain of anesthesia. Okay. And we are using muscle relaxant. Our airway instrumentation is going on. We are giving 100% oxygen and sevoflurane during this time. Can we use any other drug to maintain our plane of anesthesia?
Ma'am, can we use dexmedetomidine for children?
Why dexmedetomidine?
Infusion.
How it will help?
Ma'am, it provides very good analgesia and sedation. And also it provides a very stable hemodynamic parameters.
Stable hemodynamic parameter, so okay, it can cause bradycardia, etc., hypotension if you just increase the infusion rate. So dexmedetomidine infusion हम देंगे, but इस particular case में it will help us to maintain the plane of anesthesia because we are not dependent on ventilation during ventilation can be inadequate, and we are dependent on the surgeon for our inhalational agent. है ना? Maintaining the plane with the inhalation agent and ventilation, we are dependent on the surgeon's placement of the bronchoscope, etc. But once we are giving,
so we can use IV anesthesia.
We can supplement with an IV agent, and it is not dependent on the ventilation per se. Maintain the stable plane of anesthesia. Yeah. So combining both inhalational and dexmedetomidine. So what dose would you like to use? How dexmedetomidine can be used? Come on, fast.
Ma'am, I'm not sure. The induction dose, we're just using it for maintenance, so it'll be 0.0.
Yes.
2 mics, lower dose, 0.2 mics per kg per hour. But I don't know if it's used for pediatrics or not, ma'am.
Yeah, it is used. We can use lower doses because we are only supplementing it with, we need not give a bolus dose of dexmedetomidine, which we give. So we can use 0.3 mic per kg per hour or 0.4 mic per kg per hour. We have to see our parameters of bradycardia to nahi ho raha hai, hypertension ho rahi hai while doing that. Because we are supplementing it with our inhalation agent. We are not using it as a sole anesthetic agent. Okay. It will help us maintain stable plane of anesthesia even when there are during the periods when the airway is open and we are not able to maintain airway with plane of anesthesia with the inhalational agent. Okay. What else can we use? We have to use something which is not hampering. What else can we use? We can also use propofol fusion. Okay.
Ma'am.
Low doses. Next, Can you tell me how are we going to ventilate the case? Would you like to prefer a hand ventilation or would you like to put the patient on the ventilator during this?
Ma'am, we would like to hand ventilate the patient, especially when there are episodes of hypoxia and hypercarbia.
Also, right?
Also, during the entire procedure, we hand ventilate only. It's also very important because there will be episodes of hypoxia and hypercarbia, and we with the bag in our hand, we'll be able to
Yes.
ventilate properly, ma'am, and be able to
uh,
feel the
See,
pressures and the
the
resistance
airway is
properly.
not entirely in our hands. We are coordinating the surgeon. Suppose surgeon wants now to stop us from ventilating, he's retrieving the foreign body. So we can do that immediately, right? For seconds, we can
Ma'am.
stop our ventilation. Then another thing is, suppose there is
And we'll give gentle IPPV.
gentle IPPV can be given. We can give tidal volume according to the resistance of the patient. So we generally prefer to ventilate the patient on our hands. We can gauge the compliance of the chest or the resistance, etc. While the surgeon is manipulating the foreign body and the bronchoscope in the airway. So we generally prefer to use hand ventilation.
Hand ventilation. Yes, ma'am.
Okay. So next we come to the now suppose we have discussed in our anesthetic considerations that surgeon can drop the foreign body. Surgeon wants the field, the vocal cords, all to be immobile. Okay? During the procedure, there can be too much suction, too much bronchoscope can be moved in and out of the airway, to which there can be airway edema can be present. Now, when we are coming towards the end of the procedure, either the foreign body is out or the foreign body remains inside. So, if the foreign body is left inside, what problems can we have? The same bronchus, we are not able to do. What else can we have? Compromised airway will persist, you know. Normally, what happens is that when we remove the foreign body, if there are certain fast and present beyond distal to the foreign body in the bronchi, etc., we can suck it out. Okay. So once the surgeon has removed the foreign body, what else surgeon would do? The removal of foreign body, what else surgeon would do?
He would, ma'am, they will explore the distal airways.
They will do again check bronchoscopy to see what?
To see
So
any
one more
remnants
thing
of
is
foreign
important
bodies
thing
dislodged
I
further
forgot to
down.
tell you. No, foreign body has been taken out. Now he's doing post-operative check bronchoscopy to see if there is any remaining foreign body.
Remnant.
There is another foreign body where any segment of foreign body has remained somewhere. If there is lot of secretions of pus which need to be suctioned out, if there is subglottic edema or glottic edema for which patient may need ventilation later or nebulization later, he has to check all these things. So always a surgeon will always do a post-op check bronchoscopy for finishing off his procedure. Okay.
ठीक है.
Now there are certain things. Now once we have reversed, the surgeon has removed the foreign body. He has done check bronchoscopy. One thing I forgot to tell you is that while we are ventilating with the bronchoscopy, we have to monitor the chest movement as well. Okay, that is very important. And will ETCO2 be reliable in these cases? ETCO2 monitoring, will it be reliable?
No, ma'am. Since the air, since it's not a closed airway per se,
Yes.
so it will
So
escape to the
ETCO2,
environment
there
and
may
it
be
won't be reliable.
hypercarbia occurring and yes, there may be hypercarbia.
Also, VQ mismatch if there's any atelectasis further below the
That is
level of
more
obstruction.
far-fetched, but normally while you are ventilating, ETCO2 may not be the true ETCO2 because most of if the area is open, most of the CO2 may be leaking out of the open distal proximal end of the bronchoscope. We cannot, so we can do ABGs in between if we want to, if we are not sure of our ventilation status. Yeah. See what is the CO2 and PaO2 for PCO2. Okay, so now in the post-operative period, what are the how will you monitor the patients? What all complications can occur? The immediate post-op, we said that there can be bronchospasm and laryngospasm, right? So what will we do to prevent, treat? There is a bronchospasm. Post-extubation, we can always nebulize the patient, etc. If there's a laryngospasm, you have to know the treatment of laryngospasm. Case examiner can ask you then and there, like, how will
Hello?
you, if there's a laryngospasm? Yes, can you hear me?
Oh.
Can you all hear?
Yes,
Hello, can
ma'am.
you hear me, Jairam?
Yes, ma'am.
Post-operative complications. I'm talking about post-operative complications. So
Yes, ma'am.
what are the post-operative complications that can occur? What will we
Ma'am.
do to prevent it?
Yes, ma'am. Ma'am, since during the procedure, there is a like lot of manipulation of the airway. So post-operatively, there are high chances of airway edema can occur, or there is the chance of bronchospasm, laryngospasm can occur. Then bleeding can also occur because of the injury to the mucosa and airway. So to prevent that, one is we have to nebulize the patient with Budecort or Duolin, or we can give intravenously dexamethasone to reduce the edema. Then you can give epinephrine nebulization also.
How much epinephrine?
Ma'am, you can give 2.25% of racemic mixture you can give.
रेसिमिक तो आता ही नहीं है ना, रेसिमिक एड्रेनलिन नहीं आता है हमारे पास, तो we can
Yeah, you
normal
can give
adrenaline.
1 in 1000 dilution. You can take 1 ml of the ADR and mix it with 3 to 4 ml NS, and you can nebulize it.
Yes, you can do that, but then what monitoring you should be doing while nebulizing with epinephrine?
In that case, you have to monitor the ECG for heart rate, any changes in the like arrhythmic changes, and all you have to monitor.
There can be arrhythmias, especially अगर कुछ भी hypoxia या hypercarbia, there can be very severe arrhythmias with the adrenaline. So we have to always monitor ECG if you are nebulizing with adrenaline. Okay.
Yes, ma'am.
So
Yes, ma'am.
dexamethasone we have already given in the preoperative period a high dose, and for in the postoperative period you can give 0.1 milligram per kg 8 hourly for next 2 to 3 days to prevent the further edema, airway edema to occur. Okay, so and then you will give humidified oxygen.
Yes,
Would you
ma'am.
like to do a chest radiograph?
Yes, ma'am. The chest radiograph after like 6 to 8 hours after the procedure to check for the changes in. Yes, ma'am. To check for any barotrauma features like airway tract, intestinal shift.
And also to assess improvement in your whether atelectasis has improved or hyperinflation has reduced, because they will not improve immediately. It takes
Yes,
few
ma'am.
hours for them to improve. You can check that also.
Yes,
Also now there are certain cases which may have to be sent to ICU in the post-operative period. Can you tell me what patients are those?
Ma'am, if the patient is like more at higher risk of airway hyperreactivity, if the patient has a history of any asthma and all, in such cases, asthma with foreign body and foreign body.
आत्मा में क्यों हम फॉरेन डालेंगे? पोस्ट ऑप में
No,
फॉरेन
no.
बॉडी निकल चुकी है. Cases who have severe laryngeal or subglottic edema, or who have
Edema,
severe bleeding or tracheal perforation or injury has occurred, or patient who
Yes,
was
ma'am.
preoperatively having consolidation collapse and not maintaining saturation, that
Yes,
patient will always be sent to ICU for post-op ventilation. Or foreign body has gone to the other bronchus probably, and the previous bronchus still inflamed there. और पेशेंट को लंग एक्सेस की हिस्ट्री है कोई, या फिर कोई न्यूमोथोरैक्स न्यूमोमेडियास्टम हो गया. In those cases, you will send the patient to the
Yes, ma'am. Or if the
post-op
yes,
ICU ventilation. Okay.
ma'am.
Now, suppose you are ventilating the patient operatively, and suddenly the BP falls, and there is a bradycardia. What will you suspect?
Ma'am, there are chance of airway trapping and
Tension pneumothorax. Tension pneumothorax.
tension pneumothorax का हो जाए.
So you have to always be ready with tension. And how will you treat it immediately?
Ma'am, in tension pneumothorax, you have to stop the procedure first and tell the surgeons to remove telescope and then tell the surgeon to remove bronchoscope also. Then you intubate the patient and then you have to reduce the
टेंशन pneumothorax में कभी इंक्यूबेट करके आईपीपीवी नहीं देते हैं. टेंशन pneumothorax का सिंपल ट्रीटमेंट है needle thoracostomy. The second intercostal space. That's it.
Ma'am, fifth intercostal space.
पहले तो नीडल करते हैं ना, बाद में चेस्ट ट्यूब डालते हैं. इमीडिएट ट्रीटमेंट तो सेकंड इंटरकॉस्टल स्पेस डाल देते हैं ना नीडल टू रिलीव द टेंशन.
मैम फिफ्थ इंटरकॉस्टल स्पेस में.
अरे यार आजकल फिक्स हो गया होगा, बट ट्रीटमेंट वही है कि नीडल thoracostomy करो पहले एंड बाद में फिफ्थ इंटरकॉस्टल में चेस्ट ट्यूब डालो. आई एम ओनली आस्किंग यू. चलो अभी बहुत इंपॉर्टेंट चीज रह गई है. We have to discuss other modes of ventilation besides IPPV. Okay?
Yes, ma'am.
So
Yes, ma'am.
this we are not going to speak in exams unless asked. What else? What other ways of ventilating a patient can be there? Then you can say we can also have patient can be kept on spontaneous ventilation. Patient can be given jet ventilation, manual jet ventilation, and patient can also be given high frequency jet ventilation.
Yes,
Apneic insufflation is totally out if we are using a cast or ventilating bronchoscope. We are used to do it. हम क्या करते थे apneic में कि हम पहले पेशेंट को हाइपर वेंटिलेट कर लेते थे, मास्क से वेंटिलेट करके, और फिर सर्जन ब्रोंकोस्कोप डाल के मैनिपुलेट करता था. जब हाइपोक्सिया होने लग जाता था और हाइपोकार्बिया होने लग जाता था, then we would ask surgeon to remove the bronchoscope and then again we would hyperventilate the patient with 100% oxygen with mask. But it is no longer required as we have ventilating bronchoscopes. So no further discussion on that. Now another important thing is why can't we keep spontaneous ventilation में हम patient को क्यों नहीं रखते हैं आजकल? There are certain advantages and disadvantages. Jairam, can you explain?
Yes, ma'am. Ma'am, spontaneous ventilation. In this case, we will be like patient will be on inhalational and just TIVA. So the advantage here is there is no risk of pushing back the foreign body. Distal dislodgement nahi hoga in spontaneous ventilation, and there are a lot of disadvantages here. The disadvantage is like it's difficult to maintain an adequate plane of anesthesia, and then TIVA may like if you use propofol, it may suppress cardiac output and respiratory drive of the patient, so it makes spontaneous respiration inadequate. Then during instrumentation itself, it increases the airway resistance, and it will reduce the efficiency of the spontaneous respiration. Then there is still active airway reflexes are present. Vocal cord is mobile, so while removing the foreign body, it may stuck in the vocal cords. Then there are chances of laryngospasm, bronchospasm in a spontaneous ventilation.
Very good. So did you say that कि अगर plane deep नहीं है तो plane deep ही नहीं, अगर ज़्यादा plane हमने deep कर दिया inhalational से तो there can be respiratory depression and myocardial depression and hemodynamically instability.
Unstable also. Yes, ma'am.
So it is a very precarious balance that we have to maintain and not so deep that it can cause suppression of respiration and myocardial depression, etc. Okay, so that's why spontaneous ventilation. Spontaneous ventilation का एक ही advantage ज़्यादा बोलते थे कि IPPV से distal migration of the foreign body can occur, but there is no scientific evidence on that. And another advantage of spontaneous ventilation is that even if the airway is open, the distal end of the bronchoscope is open, patient can always take in the spontaneous ventilation can always continue. Right, because there is no loss of negative pressure से spontaneous ventilation, negative inspiration होता है ना, it will always suck in the ventilation agent and everything. Now, can you tell me what are the advantages of IPPV or the spontaneous?
IPPV, ma'am. IPPV advantages here, it will improve the oxygenation, then it will compensate for the increased airway resistance during the instrumentation, and you can maintain the adequate and constant depth of anesthesia, and patient ka hemodynamic stability will be better, and the patient will be completely immobile. Vocal cord will be immobile, so there's no delay in the foreign body removal.
Important तो यही है कि patient
Um,
will not have laryngospasm, coughing, bucking, and
Wha-
patient will have relaxed glottis at all times, है ना? और फिर जब
I-
coughing, bucking, laryngospasm नहीं होता तो tracheal rupture भी नहीं होगा, etc. ठीक है ना? Unwanted
Yes,
vocal
ma'am.
cord motion नहीं है, improved oxygenation and ventilation can occur, and rapid recovery with the attack reflexes can occur because spontaneous में deplane हो जाता है बहुत ज़्यादा तो आपको time लगता है, okay?
Yes, ma'am.
And then let's come on to the manual jet ventilation. So
Yes,
do you have the slides, Jairam, to explain
Yes,
what is
yes, ma'am.
manual jet ventilation?
Yes, ma'am. Ma'am, just I have image and I will explain it now, ma'am,
Yes.
by looking at the image.
Can
Ma'am,
we ask this manual jet ventilation in your exams? They can keep it as an instrument also, and they can ask you in theory as a short note also. And in a case, if nowadays there are cards being made, so if there's a card of foreign body bronchus, it will be asked in that manual jet ventilation. Let
Yes,
us
ma'am.
see what is manual jet ventilation.
Ma'am, first I will tell what is jet ventilation. So jet ventilation is consists
No,
of.
I just want to hear what is manual jet ventilation.
Okay, ma'am. So manual jet ventilation here, manual jet ventilation. Ma'am, I will describe the device first.
Yes.
Okay, the image is showing is a manual jet ventilation here. It has one connecting tube or catheter. It's like almost 100 centimeter long and 1.5
Jairam,
cm.
I can't see the image. Can
Ma'am,
everybody else see the image?
Yes, ma'am.
Yeah, I can't see. चलो बाकियों को दिख रहा है तो अच्छा है. You explain them.
Okay, ma'am. So it has a connecting tube or a catheter. It's like it's almost 100 centimeter long and 1.5 millimeter in diameter. And there is a pressure gauge here which is color coded. Color coded, which it represents the pressure for a particular age group. So it's there are three colors here: green color and yellow color and red color. Green suggestive of low pressure, which can be used for the infants and less than like 1 years age group. And the yellow color is you can use that pressure for a older children, and the red can be used for the adult. And there is a pressure regulator here. You can pull the pressure regulator and adjust the pressure according to the age group. Then there is a oxygen source. The white color thing is that nothing but the hose which can be connected to the oxygen source. And then there's a trigger for the manual jet ventilations. This about the device description. And procedure wise, to perform this jet ventilation technique, patient you have to induce the patient like propofol, fentanyl propofol, then you have to relax the patient. All these things are as usual. Then you have to do the laryngoscope, then you have to pass the catheter transnasally under the laryngoscopic vision into the trachea. And the most important thing here is there should be open airway for the exhalation. That's the most important thing in the jet ventilation. Then the technique is like you have to squeeze that first you have to squeeze the trigger to deliver the jet and absorb the chest rise. Then if the chest rise is not good enough, then you can increase the pressure. Then you can see the chest rise. Once the chest rise is present, that means that you are ventilating properly. Then ventilation is like you have to give inspiratory breath for 1 second and leave it for the 4 to 5 seconds for the passive exhalation. And the right side images, right side image, you can see the right side image there. There's a bronchoscope, and the another one is the jet ventilation catheter is there. There is two separate channel here. It's not going through the bronchoscope. It is a separate channel. So the one major advantage of this is even if the surgeon introduce the bronchoscope more distally, still you can ventilate the both the lung. That's the main advantage here. Then our aim in jet ventilation is to start with the lowest possible pressure and look for the chest rise. then we have to avoid the high pressure. This is because it can lead to the barotrauma, like it can lead to the pneumothorax, it can lead to the pneumomediastinum, then air trapping, subcutaneous emphysema, mucosal injury. All these things can happen if you ventilate at
Okay,
a high.
okay, Jairam. Okay, Jairam. Let me just explain a little bit. You explained very well. That's very nice. See, jet ventilation, you can do transnasally. A catheter is put and placed in the trachea. Okay? So we all know it works on the Venturi principle. The jet is passed through a narrow orifice. There is a pressure drop, and then air is entrained from the surrounding to that area. Okay? So that is the principle of jet. Now, when we are giving the manual here, we are controlling the respiratory rate with our manual trigger. Okay, it's in our hand, and the pressure that we are setting is the one which is delivering the tidal volume, which is, as Jairam said, is different for all the ages. And air entrainment kahan se hoga? Around the bronchoscope. There's a bronchoscope which is going through the vocal cords to a bronchi, okay, the trachea into a bronchus, and jet ventilation catheter is on the side of the outside the bronchoscope, on the side in the trachea, somewhere in the middle. So the air which has to be entrained is going to be formed around the bronchoscope. So, and similarly, the expiration is going to occur around the bronchoscope. So the bronchoscope is too large. For example, in small children, where the broncho ratio of size of the bronchoscope to the size of the airway is very large. In these children, especially with the jet ventilation, expiration or the egress of air will not occur. So, with some after some time, there can be hyperinflated alveoli, which can then have a barotrauma, and then they can rupture. So, in smaller children, we generally do not prefer jet ventilation. Also, it has been seen that jet ventilation can push the foreign body also more distally. Another thing with the jet ventilator is that if the pressure, if the cannula is not positioned along the axis of the trachea, it is deviated, it can cause tracheal perforation because of the high pressure, or it can even sometimes puncture into the, if some vessel is around, especially with the supraglottic jet. Here it is not one. Another thing important is that although we are giving 100% to the oxygen, what FiO2 patient is receiving, we don't know, because there is dilution of that 100% oxygen with the air which is being entrained. We are not able to deliver 100% oxygen to a patient who's prone to hypoxia. Okay. These are the problems with the jet ventilator. And we have Manujet, BBM company का Manujet 3 है हमारे पास. Earlier version were Sanders jet injector as well. This you can read, but I have me and Jairam have the crux of the jet ventilation, which is a manual jet ventilation. There is also high frequency jet ventilation, which you should avoid uttering anywhere, because we are not going to use it ever. It's a separate entity altogether. Now, according to me, most of the things we have covered for this case. Another thing that you can be asked sometimes in exam is that why do we use rigid bronchoscope, and why not fiber optic bronchoscope to remove a foreign body? Jairam, can you explain?
Yes, ma'am. Ma'am, fiber optic bronchoscope is mainly for the diagnostic purpose rather than management. So here, in rigid bronchoscope, there is a separate port for the ventilation purpose, but in fiber optic bronchoscope, there is no proper channel for the ventilation. And then suction also is better in the rigid bronchoscope compared to that of the fiber optic bronchoscope.
So there's a wider channel for suction. Right. And airway instrumentation is possible?
No, ma'am. Instrumentation in your rigid bronchoscope, there's a big channel for the instrumentation for the telescope passage, but fiber optic bronchoscope, there's no channel for the instrumentation. So only you can reach till the foreign body, and then if the foreign body is small and is more distal, you can remove it with the Fogarty catheter.
So only use of fiber optic bronchoscope can be when the foreign body is too distally placed in smaller bronchioles, where your bronchoscope cannot reach. And there you can remove the foreign body using what? You can use certain Fogarty catheter होता है ना, it can use to
Yes, ma'am.
dislodge the foreign body. The balloon can go, catheter can go beyond the foreign body distally. You can
Yes, ma'am.
inflate the balloon and then dislodge the distal foreign body using the Fogarty catheter, which can be passed to the fiber optic bronchus. Yeah. More or less, I think we have covered. Any questions that you people want to ask, you can ask me. This case can come to you in theory exam also. Very frequently this is asked, and you can be asked about this while showing an X-ray. You can be shown an X-ray in the table viva and asked about the foreign body, bronchus management. Be shown a jet ventilator or a bronchoscope in your instrument table viva and then asked about the anesthesia considerations, etc. Another thing that we missed, some consultants would previously use intermittent succinyl choline, paralyze the patient. Veeram, can you tell why we should not be using it nowadays? Why we
Sorry,
not?
ma'am, can you
Why
please?
we are not using succinyl choline intermittent
Mm,
for paralyzing the patient?
Yes, ma'am. Ma'am,
Child.
succinyl choline, if you give like, intermittent, if you use succinyl choline like more than 4 mg per kg body weight, it can block the, it can act like a non-depolarizing neuromuscular agent. Phase to block, ma'am.
The most important thing is that succinyl choline has a very
And
short duration of
bradycardia,
action.
it called bradycardia,
Huh.
ma'am.
Now, FDA has also given a black box warning about the use of succinyl, especially in children with the risk of malignant वो myasthenia gravis होता है ना, या malignant क्या होता है, myasthenia, myopathies, etc. Is not to be. Secondly, it has a very small duration of action, and then when we are using intermittent, there is generally a chance of patient going into phase 2 block.
Phase to block.
Procedure is long, we cannot give more. If
Yes,
patient
ma'am.
आपने 4 milligram per kg या ऐसे कुछ बच्चे में दे दिया, उसके बाद भी procedure अगर it is going on, then you will have to ultimately give a non-depolarizing muscle relaxant only. So why not give it beforehand only? Short
Yes,
duration
ma'am.
of succinyl choline will not help even if there's a, because कितनी देर में इस choline से patient बाहर आएगा, at least 8 to 10 minutes. अगर उसमें कोई hypoxic injury होनी है तो हो जाएगी patient को, whether you've given a succinyl choline or a non-depolarizing muscle relaxant in an obstructed airway. Okay, so succinyl choline generally we don't prefer to use it, and also when the patient is coming out of the succinyl choline, he can cough and buck, which with the bronchoscope inside can cause perforation of the airway. So it is generally not being used nowadays. This question can also be asked to Yogi, why you are not preferring in your why you don't want to use succinyl choline? Why are you using Northiron, Vectron, or any non-depolarizing muscle relaxant? So any questions you want to ask, you can ask. I think we have covered more or less everything. Another thing that I want to cover, which may be never asked to you, but suppose there is a child has severe respiratory distress and he is also full stomach. ठीक है, अभी हमने कहा ना कि हम जनरली हम ऐसे केसेस में हम क्या करेंगे, हमें इधर फास्टिंग का हम नहीं कर सकते बिकॉज पेशेंट सिवियर रेस्पिरेटरी डिस्ट्रेस में हमें ऐसा बच्चा फुल स्टमक के साथ ही लेना है और पेशेंट सिवियरली ऑब्स्ट्रक्टेड है, तो ऐसे पेशेंट को तुम कैसे इंड्यूस करोगे? Anybody has thought about this? Jairam, have you thought about this scenario?
Hello, ma'am. In such cases, if you if the patient comes with severe respiratory distress and you have to immediately do the bronchoscope and remove, in such cases, you can at the beginning you can give little sedation and you can put a Riles tube and suction all the gas
Sedation तो
contents.
बिल्कुल भी नहीं कर देना है. Patient is
Ma'am,
already obstructed. Sedation can
Ma'am.
cause complete airway obstruction. हाँ.
Ma'am, immediately you are going to do the bronchoscope and you are ventilating the patient.
No way. Pre-op में कोई sedation नहीं है. On the table of, you're saying on the OT table?
Yes, ma'am, on the OT table.
What
Anyway,
will
you
you
are
write
ready
in
with
this?
all the emergency drugs and ventilating thing. In such cases, you can pass the Riles tube and drain out all the gastric contents.
Yes, very good. You can do that if the child allows. और
Uh,
क्या कर सकते हैं इसके बाद?
Then you can give aspiration prophylaxis.
Yes, you will do that. वो तो तुम दोगे ही, बाकी सब भी जो तुम्हारे एंटीकोलिनर्जिक है वो दोगे, है ना? जो हमने
Yes,
बात की थी सारे, ब्रोंकोडायलेटर दोगे, एंटीकोलिनर्जिक, ग्लाइकोपाइरुवेट दोगे, स्टेरॉइड दोगे, है ना? ये सब तो देना ही देना है हमें। इसके
yes, ma'am.
अलावा तुम इंडक्शन पे पहुंच गए हो, तुम्हें रिस्क है, पेशेंट फुल स्टमक है, तो तुम्हारा मोड ऑफ एनेस्थीसिया क्या होगा? You like to paralyze the patient here, or would you like to preserve the spontaneous ventilation?
And spontaneous better होगा.
Spontaneous better होगा. Why? Because you don't know how much
You-
is how anytime this partial obstruction can become a complete obstruction, and you can lose the airway after paralyzing. And severe
Yes, ma'am.
respiratory distress generally occurs in cases where the foreign body is near the larynx or the trachea, right? And
Yes, ma'am.
these are at the chance of becoming at the higher chance of becoming obstruction, causing complete airway obstruction. So you would like to, but with the airway so much blocked, your spontaneous inhalational induction will takes very, very long. Now, talk
Yes, ma'am.
about it, very, very long for induction. So we can always supplement inhalational with IV agents, which would not interfere, which would not cause respiratory depression, and which would preserve your respiratory drive. Can you name any which will not cause IV agents which will not cause your respiration to get suppressed? Supplement करना पड़ेगा ना spontaneous CO inhalation को, because otherwise
ma'am.
spontaneous induction is going to take too long. Child can aspirate. Anyway,
Yes.
during bronchoscopy, there is a chance for aspiration. We are going to use metoclopramide, Rentek, etc. Try to empty the stomach with a IS tube beforehand. We can induce the child of respiratory distress even in sitting position after pre-oxygenation, 100% oxygen, and then make once he is induced, then we can make him lie down. So to fasten the induction, we will have to supplement with the IV agent, which will preserve the spontaneous respiration. So one is dexmedetomidine. It does not cause respiratory depression. We can also use IV ketamine. Will sedate the child, but will not will not cause respiratory depression. You know?
Yes, ma'am.
You can supplement with these, and then once the surgeon has inserted the bronchoscope and has localized the foreign body, then probably you can paralyze the patient if needed. Okay?
Yes, ma'am. Yes, ma'am.
हाँ. और अगर आप deep plane maintain कर सकते हो, तो you can continue with spontaneous ventilation in such cases as well. This is one thing which I just thought about it, although I've never faced it clinically ever. But this can occur, so I was thinking how we can manage such a case. You can write it in your notebooks if you were asked about this. Yeah. Anything else, Jairam, that we may have missed? Anybody else who wants to ask
Covered
a
almost
question?
all that.
About what?
Almost all the topics we have
Jairam?
covered. Ma'am?
We have covered almost it.
Yes, ma'am. We have covered almost all that.
I think we have covered almost everything. Okay. Let us now and then finish off with this class. Thank you for your patient hearing and good presentation by Jasmine and Jairam. Please read this
Thank you, ma'am.
again. You can read through the Gregory, Pediatric Book of Anesthesia, Benioff, the chapter Rigid Bronchoscopy, and also go through this thing, up-to-date lectures. Then there are certain slides which Jairam can give you, or you can find on the internet. Thank you. Thanks a lot.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.